Hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, along with my wonderful wife, Janet, and we are streaming live from the Team Needham Abode podcast studio. And we are super excited to have Dr. Yazan Abdullah back on our podcast today. He specializes in men's health and specifically hormone replacement therapy down in Southern California. As we wait to get him connected, Jan and I are going to kind of go into the subject a little bit already and maybe use a little bit of examples on to show people how insurance hinders comprehensive patient care. So, you know, I have a friend that had his ankle fused, a friend from high school, and just recently, and he posted on social media about how the titanium screws in his ankle were $8,000, the titanium screws. Now, that's ridiculous. We all know that. You know, you could probably, the titanium screws are probably really honestly worth a couple $100 maximum. So why was it $8,000 is you have to ask. Now, one thing that he said is, I'm glad that I have good insurance. And that's part of the problem. Nothing personal against him. He might not know any better. Most people don't. And that's why we're educating people, is that when people have that attitude, I'm glad I have good insurance, then that's why the price doesn't matter, because they think that their insurance covers it. It doesn't matter what the price is. And that's part of the problem. If individuals were paying directly for their own health care, the price would definitely go down. Now, also, what does that have to do with quality and service? Well, when the insurance company is paying the bill, maybe we can come to terms that the price doesn't matter, but do you think the quality and service matters either? Janet, what are your thoughts?
Oh my, I could be here for a while. Personal experience with that is the quality of when I've paid with a insurance card versus when I paid out of pocket was night and day. I'll give you one example. I scheduled a procedure for colonoscopy at our local hospital, and it started out in the morning like it would typically go, but I ended up staying there all day waiting for the procedure to happen, and was the last patient, and they told me, well, Mrs. Needham, you're going to have to go home and come back tomorrow. And I'm like, no, I'm not doing my prep again. I'll be your last patient. But the problem with that was, not only did I wait all day for something I should have been in and out very quickly and readily, is that they had a staffing issue. And it wasn't like there was some trauma going on. It's just that they had staffing issues, which I understand, but all day. So
there's no excuse.
No, there's not. So the second time I had a follow-up colonoscopy, Shawn and I decided that we would go out of town, and we found a GI specialist who would do that in his own. He had his own suite to do that. And I was in and out. I think it started at like 6 something in the morning. I was in and out, had my results. I paid $1,100, and I was home before I even got home from my previous experience. And the quality and how I was treated was much nicer and better. And I'm not saying anything negative about the nurses or the staff at the first procedure. I'm just saying that under the working conditions that they were working in and how the day progressed and the staffing issue and the chaos of that day, that was not something I experienced when I was the consumer and the customer. The insurance company doesn't care how I'm treated. They just care about what they're going to be willing to pay. And then on top of it, when we paid with insurance, we thought, well, when Obamacare came through, we decided that health insurance was going to be very extremely high for our family, especially when we knew that we probably wouldn't access the insurance, because most of the time we didn't. So that's why we thought, well, we'll use our insurance before we decided to do a health sharing ministry. And I paid more. I think I paid like $3,000
$3,000
out of pocket for sitting there all day in a bed waiting and waiting and waiting to get in for a procedure versus paying $1,100 for a procedure where I was in and out from Spokane and home in my own home before I even was the second time. So the point is that who's the consumer? Is it either you or the insurance company? And that makes a big difference as to how humans interact with one another when you're paying the bill versus some secondary person.
That's right. When you pay the bill directly and bypass insurance, you get better quality, better service, and cheaper price. Dr. Abdullah, welcome to our show. And what are your thoughts about that?
Good morning, guys. How are you doing?
Good morning.
I just thank you guys for having me again. And apologies, we're doing this from my humble home, so ignore what's behind.
No worries whatsoever. We're glad. Welcome back.
So I just want to add a point to the very salient points Janet was saying, and she was talking about how you pay, how the financial transaction goes does affect the quality of care. But in addition to that, let's just remind people of something they already know here in America. Here in America, you work for whoever pays you. That's just that's just how humans are. And even if they don't do that on purpose and in a conscious manner, they do it in a subconscious manner. And if the doctor is getting paid by the insurance company, then that doctor is, de facto a worker of the insurance company, not yours. That you're not hired. You didn't hire that doctor anymore. So, but when you pay directly, you hired the doctor. The doctor is yours now. They're working for you. And as a doctor who has been both in a managed care setting where I took insurance and now I'm not, I will tell you, no matter how hard they train us to not look at people differently, okay, we're human. Mm-hmm. And when you pay the doctor directly, you will get better care. And sometimes the doctor will actually work even harder than they need to with the money you gave them, because just the respect alone and feeling valued, that just makes a whole lot of a difference. So, even though in medical school on day one of medical ethics class, the professor asks, and he says, if Hitler showed up at your clinic, should you treat Hitler? That's the question. And of course, the answer is, well, you're a doctor. You should not look at people of who they are and what they did. If they're at your office and sick, you treat them. In reality, not really. We're human. We are going to treat some patients better than others. That's just a fact that you can't run away from. So I think when it comes to your health, you don't attach a price to it, providing that whoever you're paying is not bilking you and giving you like a totally unfair price. So what I wanted to do today is quickly go over some examples that people can use in seeking a certain type of medicine in a managed care setting versus in a private setting. And I want to say that before we go, we have to talk about the lingo. So when we say managed care, what do we mean by that? Because there's some confusion. A lot of people think when you say managed care, you're just talking about HMOs. No, that's not it. If you go to Wikipedia and put managed care, it's not HMO. Managed care is just the idea that you didn't pay. A third party paid. So that could be government, that could be Aetna, that could be something else, but you didn't pay. You paid something like a copay or some whatever, but you received the service and the person gave you the service has to get paid later. That's what managed care is. So it's an umbrella term. And the second thing I want to highlight is that very often patients will look at a certain managed care setting, and because it's packaged in a certain way, they think it's special. So, for example, sometimes the facility could have the name of a very well-known hospital in the area. Or sometimes it could have the name of a famous university. So it says university this, Vitality Center. Okay. So now you're thinking, oh, wow, well, this is special. This is not just like, some random corporate. This is like Providence Hospital, This has got to be like the top notch. Or, for example, this is university affiliated. I bet all these doctors are current with their knowledge. It's university. So, but this is what I want to make clear to everybody watching this. It doesn't matter if it's Mayo Clinic or Podunk College or whatever university is in the name of the managed care facility. The fact that they are billing a third party means that they are already limited in what they can do for you. And these doctors, they spend most of their times at meetings, doing random stuff. They're not current with their knowledge. Even if they have a nice, sexy badge on their scrubs that says Providence, Mayo Clinic, whatever, that doesn't mean anything. And a lot of it is marketing. And today I'm going to present, and I'm going to try to be as brief as possible because I'm known to be very verbose. So I'm going to be very brief so that I can give you and Janet an opportunity to ask or add salient points to what I'm saying. Mm-hmm. So we are going to now be more specific and talk about people seeking hormone replacement therapy and vitality medicine through managed care settings versus a private care setting. And we know the attraction. We know what is bringing those people to managed care setting hormone replacement therapy. What's bringing them is this. The attraction is, oh, this is through my insurance. I can get this through my insurance. All I have to do is a $15 copay. Awesome. And then the second attraction, oh, this is happening through my network. So my other doctors are going to have access to my chart, and that will make my care really, really good. Third attraction, all of these medications are through my insurance too. And the testosterone is $20 at CVS, So you see how they go there, how they end up going there. In addition to that, these facilities have enormous marketing budget. So they will get to you wherever you are, and they will advertise this stuff. So these are the attractive aspects that bring people in to these hormone replacement clinics that are in managed care settings. But as I'm going to present some examples, these are all traps, and you should watch out for the fine print, because it's always in the fine print. So I'm going to first start with an example of a man. And then I'm going to go through an example of a woman. And I'm going to start with the man because it's a shorter case. And then with the women, we deal with multiple hormones, so it's going to take a slightly bit longer. So we'll start with a guy. So this is a real case, by the way. This is I'm not going to mention names or anything that will get us into HIPAA trouble, but other than the name and the demographic of the patient, everything I'm telling you is correct. Okay. So this is a 53-year-old man. Okay. 53, young, 53, came in to see me the first time. Nothing unusual. He's on some blood pressure medicines and whatever. Everything was fine. He came to establish care with me, and he had done his physical exam with a comprehensive lab panel 8 months before the visit with me. So, and he wants to use insurance. And so he wasn't due for the next annual until, 4 months from now, because it's an annual. So it's every 12 months. And he said to me that he was on HRT. He was on testosterone, and he was getting it from UCI. That's University of California, Irvine. Okay. So that's a really big name here. Okay. And he was getting it from their integrative center or whatever it is. And so I said to him, hey, are you up to date with your labs, with that respect. And he made it very clear that he is. And I took his word. Okay, I didn't. And he was an upstanding citizen from a good family, cared about his health, was a businessman. I had no reason to question his word. Okay. And he showed me the bottle of the testosterone he had, and then it had some in it. So he said, Dr. Abdullah, I wish to switch with you my HRT, but for now, I am under their care. I still have some of their testosterone. I'll let you know when I run out. So everything sounded fine to me, except there was something odd. The dose was 75 milligrams weekly, okay? Which is, I've seen this dose. It's usually a low dose. Doctors generally don't prescribe that, but it was there. He was on it. I didn't, and his HRT part wasn't totally transferred to me. So I thought to myself, okay, Yazan, keep things as is. And then when it comes time for you to take over, you will make the alterations that you want. So come 4 months later, which was when his new annual was due, okay? And the PSA came back at 15, okay? Are you guys here? You guys hear me?
We're
here. Yeah, 15.
PSA
Wow.
came back at 15, okay? So I was like, okay, I called the patient. I said, hey, man, this is what's going on. Please, let's repeat this in a few days. Make sure you don't jack off. No butt sex.
Right.
Don't go buy a bicycle. Don't go to spin class, whatever. Just repeat the test, okay? So the guy does what I tell him. The test comes back at 27, okay? So then 3 days later was his appointment with me. Okay, so I saw him in clinic, and I kind of said to him, look, this is what we're looking at. Frankly, cancer needs to be ruled out. You might have prostatitis that is asymptomatic. It's possible, let's send you to a urologist. So urologist could not believe it was cancer. He wasn't buying that. He said this was acute prostatitis. Let's give you 6 weeks of Cipro. Come back with a repeat PSA. The guy comes back after Cipro with a repeat PSA 190, okay? So MRI gets done a week later, metastatic cancer, and then CT scan shows cancer in all of the lymph nodes, the lungs, the liver, the colon. He was basically a moving, breathing cancer petri dish, whatever you want to call it. In 4 months, the guy died. Okay. Wow. And he died a miserable death. He wasn't around his family. He was being hospitalized for side effects of chemotherapy. It was a mess. The guy bled to death. It was nasty. Okay. So now let's go back to how this actually happened. So this dude was doing HRT with UCI clinic. This is a well-known University of California, Irvine HRT clinic, okay? Now, if you read the standards of care, like if you go on uptodate.com, I'm sure you guys know what that is. Mm-hmm. You guys know uptodate.com. Yep. So if you go to uptodate.com, uptodate.com says when you put a man on HRT, you get a PSA at baseline, you get a PSA 3 months in, and then if that PSA is normal, you get a PSA a year after. Okay, except there's a couple of problems there. Problem number one, 6% of prostate cancers at the time of diagnosis are metastatic. So what does that tell you? That tells you that even though prostate cancer is known as one of the slowest tumors, not all prostate cancers are like that. Right. There is a small percentage of them that are hugely aggressive. And those are the ones in which you benefit from an earlier diagnosis. So if you have a slow cancer that grows in 10 years, who cares if the PSA is delayed a year or 6 months or whatever? But if you have an aggressive one, you need a more frequent PSA and an earlier diagnosis. So this man for a full year did not have a PSA because UCI was following the standards of care. Now, the problem with standards of care is that you guys know these are the standards of managed care. They have nothing to do with patient satisfaction and what's good for the patient. It has to do with like cost and all that bullshit. Now, most men, if you explain to them the importance of a PSA, they'll pay out of pocket for PSA. They'll tell you, yes, please, let's do this every 3 months if you think it's necessary. So the issue with this patient was he was so happy that he didn't have to visit often and that he didn't have to get a PSA done often because of the convenience of that. But what he didn't realize is that, well, dude, testosterone does not cause prostate cancer. But if it's in your genes that you're going to get one of the aggressive prostate cancers, then if you're on testosterone, it's important to diagnose that super early so we could stop it.
Right.
And get you to a urologist. So this is one of the issues, one of the reasons why men should not pursue HRT at a managed care facility, because the facility focuses on lowering their cost, not your cost, but their cost. So less visits, less timely PSAs, and nary attention to estrogen levels, okay? And thirdly, they target a level of 600, on your plasma levels. And we all know 600 is standards of managed care to reduce cost and reduce side effects because they don't have the resources to manage the side effects. It's too much work. But in the clinical setting, most men want and feel better when they're like over 800 and like under 1500. Now, when you get them to that dose and give them the benefits they're looking for, sometimes you have to deal with polycythemia. Sometimes you have to fax over a therapeutic phlebotomy, referral, whatever. So there's some work to it. But in a managed care setting, they don't want to do that work and they don't want the liability. So guess what? They underdose you, so you don't even get the benefits. So might as well not be on it anyways. So that's what I call an effective HRT. And now I want to quickly go on a couple of examples for women, because that's actually even worse than men. And as we are all aware that recently, I feel year after year, women's health gets worse in this country. I don't know what's going on. We're going back to Afghanistan age. I don't know what's happening. But let's now switch the conversation to women's HRT. So once again, the attraction for a woman to seek HRT at a managed care facility are the same as it is for men. It's insurance. You drop a $10 copay. Your medication is sent to CVS, you pay nothing, it's all good. But there's a lot of problems when it comes to women getting HRT through a managed care facility. And we'll get to that one by one. So, and we will use the hormones themselves to guide us. So first of all, we're going to use testosterone. Let's be extremely clear that women of all ages, whether she's 20, 30, 40, 60, 70, 80, doesn't matter what her age is, she's testosterone dependent. That is a fact, a biological fact nobody can refute. She is testosterone dependent. And the proof of that is that at any age, whether you are having a cycle, whether you no longer have a cycle, you take at any point in time a blood sample and you measure testosterone and estrogen, the woman is going to carry about 100,000 times more testosterone than estrogen. Mm-hmm. So what does that tell you? That tells you that a woman is 100% dependent on testosterone for energy, for libido, for bone density, for cardiovascular health, and the things that men that give men the benefits of testosterone are the same things for women. So it's all the same. Now, women need testosterone for an additional reason. It's the source of their estrogen. So they also need it for that purpose. And so if you go to a managed care setting seeking HRT, there's a 90% chance you're not going to be on testosterone.
Not 99.
Oh.
Let's just say 99.
I'll take 99.
Remember, Dr. Abdullah, there's no FDA approved product for women's testosterone. And you know, the people in managed care, they're going through standards of care, which is pushed by big pharma. So they're just drinking the Kool-Aid. So Janet and I deal with this every day.
Right.
Yeah.
Right.
So you were being very conservative 99% of the time. And let's just face it, there's a lot of ignorance there too. You were already alluding to it, but most doctors will say women, no, they don't need testosterone. That's for men. Right. And we see it all the time.
Right. And Shawn, the reason why this is happening is that these doctors, they are so bogged down by the sheer volume of patients they have to say and they have to see and the other shit they have to do. They're not current with their knowledge. So they're behind. So you tell them women testosterone, what the fuck are you talking about? You know, well,
and by the way, that's on them. That's their fault.
No, Shawn, I
know you know that.
And you know that I am deeply critical of the medical profession. You know, if there's one outrageous, unhinged doctor who shits on doctors, it's going to be me. So I right there agree with you. So anyway, so back to the whole testosterone thing. So I'll take your percentage. 99% not on testosterone. Okay. Well, so that's problem number one. Second problem is the estrogen dosing. Okay. So they're going to put a woman on estrogen, and they're not going to target a level.
No.
They're gonna give her estrogen.
They don't even know.
They're gonna give her estrogen, and she's gonna go. She might show up in 3 months. She might show up in 6 months. She might not show up in a year. And there's no target level. Okay, if you're going to give someone a hormone, even if there's no target by the standards of managed care, I like to call them standards of managed care because they're not really standards of care. Don't you want to know if this woman is even taking the medication? Don't you want to figure that out? You know, if you're prescribing the medication through a compounding pharmacy or a generic commercial pharmacy, don't you want to know maybe there's a quality control, there's a bad batch, so she's taking the medication, but it's not bringing up her levels? Don't you want to know if her metabolism changed and now she needs less or more? I don't know. Like, don't you want to figure that out?
Right.
And then, second of all, when we give men testosterone, we have a target level. So why the fuck is there not a target level for women? Well, every doctor in this world can go on Google and look up the menstrual cycle and look at the levels and look at the time and figure it out. The first 2 weeks of the cycle, you're in the follicular phase. This is, I'm a single woman ready to party phase. The second part of the cycle, I'm ready to be a mom. Get out of my face. So you take the first part of the cycle, you look at the hormonal milieu of that cycle, and you can get a pretty good idea of where a woman should be. So basically, if you want a level that is not hypogonadal with estrogen, you got to get over 50. You got to get that level over 50. Every single woman who has done HRT through managed care and who shows up on my clinic, I look at their estrogen is in the 20s. Same as it is for someone who's postmenopausal. That's because the creams are weak. The oral dose is too low because they're so afraid of clots. They're so afraid of fucking uterine cancer. So it's all about liability, no patient satisfaction. And I tell them, I'm sorry, but it looks like you're not on HRT really. I mean, you are on it, but you're not really on it. So because the level is so low. So you have to go above 50. Okay. Now, so the other thing is take progesterone. Okay. Now, here's the deal. They give a woman progesterone. Nobody checks the levels. No one. Okay. Well, first of all, you got a problem there because if she's taking estrogen And if she's not taking the progesterone because no one explained why she should take it, or she's rationing for whatever financial reason or whatever, you're liable. Because if you have something that stimulates the uterus to grow and nothing to put the brakes on, if that woman gets uterine cancer, that's on you. So don't you want to see that the progesterone is also being taken? So you measure the levels because you want to guarantee adherence, quality control. And sometimes you need a target with progesterone, especially if you selected a woman in which you, for example, want the estradiol to be around 100 because she's looking for skin benefits, hair benefits, and not just bone. So a woman like that, you take her up to like 100 in her estrogen level. Now, the more you give estrogen, the more you build the uterus. And the more you build the uterus, the more uterus protection you need. So maybe that progesterone level needs to go from 10 to 20. So of course you have to monitor the level of that stuff. You can't not monitor it. Now, the other thing is, again, the standards of managed care, no monitoring needed. So these women are so happy. Oh, well, guess what? I don't have to pay for an extra visit. I don't have to see my doctor, until like my next annual or in 6 months. And she goes there, she sees the PA, she doesn't even see the doctor. And then nobody does anything about the dosing. Nobody checks the hormone levels. But then you check when they come to another doctor like me for a second opinion. I look at their labs and I'm like, well, first of all, it doesn't look like you're on estrogen because it says your level is 15. So that's probably what your body makes anyways. Right. And then your testosterone is sitting at like 15. So, and progesterone says undetectable. So I don't know what's going on, but you're not on HRT. So these are the important issues. Now, I just want to say that these are not minor. If you are on estrogen, you need to be on enough estrogen to get the benefits. Yep. And the higher the estrogen is, the higher the progesterone must be for you to get uterine protection.
And let's just clear this up too, Dr. Abdullah, and I want you to comment on this. Standard of care, what we learn in pharmacy school, what you learn in med school, progesterone is only needed if you have a uterus. And that's what doctors are taught. That's what pharmacists are taught. But let's remember, progesterone is needed regardless of if you have a uterus or not. It works in the bone. It works in the brain. It works all over in the breast. So progesterone is important whether you have a uterus or not.
Right. Comment on that? Right. But yes. However, the benefits you're talking about, bone, breast, brain as a neurosteroid, yada, yada, these benefits can be obtained by the other hormones, and they're usually more pronounced by the other hormones. And as a neurosteroid, progesterone can be locally made in the brain, and the amount that you make is generally enough for these purposes. So in the context of HRT, indeed, progesterone is needed as an extra measure for uterine protection. But your point is correct. Uterus, without uterus, you need it. But without the uterus and without progesterone in HRT, the native production of progesterone from the brain and from other glands is actually sufficient to meet these needs. Because if you look at the steroid genesis, this huge chemical diagram that shows you where all the steroids come from, progesterone is right there early. It doesn't require that many enzymatic reactions. So you will have a little bit of it that's enough locally to do the effect. So that's that. And finally, I want to make a comment about thyroid. Okay, a lot of men and women are on thyroid, and it's not always Hashimoto's and all that crap. It's just age related. When you get older, sex hormones go down, thyroid goes down, growth hormone goes down. That's just what happens. Most women are either underdosed with thyroid or overdosed. And the reason why that happens is because The thyroid medicine must be changed based on weight. It must be dosed based on weight. And when you go to a managed care setting and they're seeing you every 6 months or every annual, and you present with 10 problems, nobody has time to change your thyroid medicine to your current dose. So again, all these patients are happy. Oh, I don't need to see my doctor. I don't have to pay. Oh, it's all good. Well, guess what? You have atrial fibrillation and you're hyperthyroid. So what do you want to do about that? Or you're on thyroid, but you're actually underdosed. That's why you're always fatigued and you're always complaining and you're always depressed. So that's so again, I want to end this and then turn it to you guys. Is that for hormone replacement therapy, which is frankly speaking the only effective aspect of primary care in this country. In Western medicine, the only thing that fucking works is hormones. So if you are going to do that, please do that in the private setting. Do it with a doctor or someone who is knowledgeable, who does this day in and day out, and don't use it with insurance. Because remember, if you apply insurance and if you make the doctor send the prescription to CVS, that doctor is limited in what they can prescribe to you. Do you really want that progesterone to come from Teva and smells like ass, has been stored for 1 million years and doesn't work anymore? Do you really want that? Like, doesn't your health matter to you? So once again, do you not, as a woman, do you not want the chance of being able to take oral testosterone instead of having to inject it? Because you know what? Compounding pharmacies make it in oil suspensions, in little things that you can take that are absorbed by the lymphatics, and it's very safe. So again, when it comes to your health, okay, it's important to think about price and money. We should always think about that. Mm-hmm. But also think of quality. And that's the part that people are missing. Managed care is selling you low quality for a high price. So if you're going to pay the high price, get good quality.
Absolutely. I love it. And one of our listeners and viewers are Wayne Bailey says, love this doc. So thank you, Dr. Abdullah.
Thank you.
And here's one thing
I'm not always lovable. I'm not lovable on Twitter, but thank you for loving me.
Yeah, that's why I love following you, because you and I, man, we get some engagement from people that don't like the truth, I think, One thing I want to comment on about hormone replacement, and hormone replacement is mostly what you do. It's mostly what we do. And I got into some debate with some traditional doctors a few days ago on social media.
Uh-huh.
And they basically said that prescribing hormones is no different than prescribing medications for diabetes and hypertension. And yeah, right. Yeah. And I get it. I mean, and that's what the traditional managed care system will tell you. That's what the standards of care are. Prescribe estradiol at this dose. Don't do any follow-up. Prescribe testosterone at this dose. Don't do any follow-up, blah, blah, blah. But here's the reality of people seeking hormone replacement for us. People aren't seeking hormone replacement at our facility to just survive. They want to thrive. In order to thrive, right? Absolutely. Exactly. That's the kind of patients we take care of. And I love it, because they want to feel better. And they've got skin in the game. They're paying for it up front. We want to help them. And let me just finish this and then I'll let you go. Here's the reality. Go to a doctor that not only will prescribe appropriately and monitor appropriately the HRT therapy, but also let you know that it's a piece of the puzzle. Mrs. Jones, Mr. Jones, you can't eat like crap. You can't not sleep. You can't not exercise and just magically think this hormones are going to change your life. Right. So here's one of the things. First of all, as healthcare professionals, if we want our patients to be healthy, we should be healthy. You're walking the walk, you talk the talk, and so do we. And then we can teach our patients about that also, because hormones are just a piece of it. If you want to thrive, you have to, it's a piece of the puzzle. You have to exercise, you have to diet. Diet is very important. Sleep is very important, more important than exercise, So that's really it. If you want patients to thrive, go to a doctor that's thriving himself or herself and knows the complete picture, not just how to prescribe the medication. Janet.
Okay, so very importantly, what I'm hearing from this discussion today, Doctor, from you is you actually have a goal with your patient. And that's not in the so-called standard of care.
Correct.
It does not equate to quality.
Right. No, patient satisfaction is not in the equation.
No.
100%. In order to achieve your goal, you have to have the tools in front of you to do that. And very clearly, you are looking at your tools and saying, okay, if I do this lab, what do we have to hit to have the outcome that's optimal for this person? Not what you're just going to get.
Right.
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 So when the patient leaves, they are a part of that because they're the ones that are following the therapy. And if they don't buy in with what you've prescribed for them, those prescriptions still sit in my computer without ever being filled, without ever understanding how it plays to importance in their life. So what you do in your practice is you manage their hormones, but you tell them why and how that plays out and how that's important to their outcome. So that's different. That's skin in the game versus just go home and do it, Mrs. Jones.
Right. And the thing is, when you are in a managed care setting, the doctor doesn't need to give you good results.
No.
The doctor will still have his job. That's
right.
You know, and in fact, they love it if you disappeared and they get more turnover. That's right. Whereas the private doctor is a hustler. They want you to come back. So they're going to bend over backwards, give you results so that your ass comes back and pay. So they have skin in the game. The doctor wants to deliver results and they promise you these results. They want to deliver them. They want a good Yelp review from you. They want you to refer their friends. So they have a vested interest in making, an impact. Secondly, you just mentioned it, Shawn, you were saying that hormones are not like lisinopril when you prescribe them. Well, yeah, because the hormone requires a hormone receptor. And I cannot guess genetically how your makeup and in what tissues and parts of your body are the receptors more distributed than others. I have no idea. We have to give you the hormone and check your shit and see how you're responding. So I have a man who is, 35 years old. You give him 200 megs of testosterone a week. He became Arnold Schwarzenegger. And then I have men who are in their 40s and they won't feel a thing until you up the dose to 400 megs a week. Because they have different receptors.
Everybody's different.
Yeah. Now, of course, if you look at the standards of care, I could be sued. Dr. Abdullah, you're prescribing 400 milligrams a week, that's not the standards of care. Well, these are the standards of managed care, and these are medical legal, and my patient who is safe and satisfied with my results is not going to go to the medical board.
Agree 100%. Let's just clear this. I debate with doctors all the time on this about, getting sued and all this. The number one reason people sue you is because they don't like you. Right. So if you are honest with the patient and you take care of them and you make them feel better and you do the right thing and speak truth with them, then the chance of them suing you are very little.
Right. Right.
That's what's good about having a personal relationship with them.
Right.
And that's the same as we have in our pharmacy. And just talking about, we have skin in the game at our pharmacy because we don't bill insurance. So we bend over backwards for the patients because they are paying our bills, literally. And we understand that. So we make sure that our staff gives good customer service. Right. We don't have some insurance network sending us a bunch of patients. We need everyone that comes in. Right. So we're going to take care of them well. Right. I had another example of, the managed care problem and prescribing is, when thyroid's a perfect example is, being referred, primary care doctors talk about, being referred to endocrinologists and the Endocrinologist Society says this and it's like, well, I will tell you, when we have patients that come to us and they say, well, I want to be sent to an endocrinologist that bills my insurance. First of all, we'll tell them this. Most endocrinologists, I wouldn't recommend. Now, maybe Dr. Abdullah, in Southern California, there might be some endocrinologists that are pretty good at HRT. I know Suzanne Summers had an endocrinologist that did. But I don't know the details. So, I mean, in our area, I wouldn't refer to a standard endocrinologist. They treat diabetes, and they're not good at that, in my opinion.
Yeah.
And so when we get a patient, we've been doing this long enough now. When we get a patient, they say, I want to go to a hormone doctor that will bill my insurance. We just tell them no. We just tell them, we refuse to refer you to somebody because you are not going to get the best care. Here's a list of people that we recommend that you would get good care from. Because here's the problem. We realize, because they said, well, you can work with my doctor. No, we can't. I'm not working with a doctor that bills insurance. I'm not going to be handcuffed by that, So,
right.
I mean, and people still sometimes just don't get it, but that's why we're having this podcast, this conversation.
Right. And my mother-in-law, she's 67 and very, very healthy woman. She, for years, had been trying to be on HRT. And of course, all the gynecologists tell her, no. You're 10 years past menopause. We're not going to touch you. And of course, I started her 6 months ago, actually. She's been on HRT. She is doing absolutely wonderful. I didn't do that because I'm irresponsible, but because it's on a case-by-case basis. If you look at a 67-year-old woman, she's not on any medications. She's healthy as a 20-year-old. There's no reason you can't put this woman on HRT. She's doing great. She's doing fantastic. But again, you go to a managed care doctor. I'm not touching this. Medical, legal, whatever. So that again goes back to.
But by the same token, those doctors would prescribe Fosamax for her bad bones, her osteoporosis. They would prescribe Macrobid for her urinary tract infection. They would prescribe Ditropan for her urinary incontinence, and they would do that for the rest of their life.
Right.
My gosh, do not put them on hormones.
Right. It just makes makes no sense. And yes, and Southern California is not different. Endocrinologists are very, very useless here. Frankly, I don't know why that is. As an endocrinologist, you think you'd be like the pro at like hormones, but they do just diabetes and thyroid, and the job is average. Because again, the thyroid is not dosed based on weight, because some of these are HMO clinics, so they don't want you showing up. They got to get the capitation fee at the beginning of the month, and they want to keep you out of the clinic, as long as possible, and they give you a month's supply with 11 refills. And so the patient, the naive patient that is thinking, oh, that's great, I'm saving money. They gave me a 1-year supply. Well, guess what? Nobody's assessing you. So good luck, good luck with that. So, yeah.
Well, and a topic for another conversation or a podcast episode, but, the way they treat diabetes is horrible. I mean, as well as I do, Dr. Abdullah, that diabetes, you don't lack a medication in diabetes. You have a diet and an exercise problem, a lifestyle problem. Yep. And doctors like you that know hormone replacement and know health and wellness can take the time to educate these people about that. Whereas that's not what an endocrinologist does. They just prescribe another drug to try to get their glucose levels down. And they do that because they are paid based on the hemoglobin A1C rate and what drug they put somebody on to fix this problem, right? I mean, seriously.
And they got to get you out in 5 minutes. And 5 minutes is not enough to talk about what's the type of diet and exercise. Right. And here's the most embarrassing part. If you do give them the time to talk about diet and exercise, they still can't, because the doctor, him or herself, is not healthy.
Right, absolutely. I mean, Janet had said that.
How embarrassing. How,
Janet, tell the story
embarrassing.
really quickly.
So I had a client that was trying to, actually, she was really working towards, a better weight. She wasn't that far out of her weight range, but she wanted to achieve this. Good for her, right? And she went in and her doctor gave her just horrible diet advice. I was horrified. So over the phone, I'm getting
what was one of them? Go ahead and tell Dr. Abdullah and share it with our listeners and viewers. It was red meat, right?
Well, she wanted her to just go more on a plant-based is what I was understanding. So
I know, right?
So I did not argue with the diet part, but I said, okay, let's back up and who's giving you this advice? I just want to know, is the person in front of you giving this advice living the walk? Is this person in her weight goal? Is this person or him? Tell me about that. And it was just silent. And I said, okay, then let's back up and look at the people who are achieving these goals and how do they get to that?
What are they eating?
Yeah, exactly, right.
So it was very, you could tell where I was going because, Shawn uses this analogy. Would you go to a dentist who had crooked teeth and yellow?
Absolutely.
And I mean, let's really be truthful about this. So in healthcare, let's back up and say, okay, if somebody's giving you advice and it's not matching up with what you're hearing and seeing, run.
Right. No, I totally get you. I mean, obesity is an epidemic in this country. Mm-hmm. And last time I checked, the only source of carbs is plants. So they talk about plants. I don't know. Last time I checked, potato is a plant. Rice is a plant. Bagels are a plant. Donuts are a plant. Last time I checked. So that's how good plants are, supposedly.
And the whole red meat scare, and red meat causes, cardiovascular problems and all that. That's just the most ridiculous thing I've ever heard. It's like, if we, as humans, we've been eating red meat for thousands of years.
Right.
If it wasn't good for us, it would have killed us years ago.
Right.
And decades ago, centuries ago.
Right. And the thing is, suppose red meat is bad. Let's make that assumption. So are you telling me it's worse than obesity?
Yeah, right.
So nobody's going to buy that. No, nobody's going to buy that. But that's, and I have to say, it really shames me. It really shames me that so many doctors are unhealthy. You have no idea. So many doctors are not just poor diet, poor exercise, metabolic syndrome, addicted to benzos, alcohol, fatty liver disease. I mean, the doctors are really, sometimes you question, are these people really in the right place to impart medical advice? Is that really the case? I mean, most of them are stroking out at 65. That's hardly an example of longevity and health. So,
and I, Dr. Abdullah, I blame managed care on it.
Of course.
How many patients would you get in your clinic if you were metabolically unhealthy? You would get almost zero. I mean, seriously, you wouldn't get that many.
Right.
But when you sign up with insurance companies and they send you business, you don't have to walk the walk and talk the talk. You don't have to. Right. They're just going to come to you because the insurance company told them to come to you, and that's the problem.
Right. And Shawn, because they see 30 patients a day, the doctors themselves actually don't have time to read up, be current in the knowledge, and exercise, and cook and pre-cook their meals on a Sunday so that they can have a decent meal throughout the week. So managed care not only encourages low quality care and disincentivizes the doctor from becoming healthier, but it also causes the doctor to be unhealthier. Mm-hmm. So that's kind of what it does. But we must not forget the role that doctors themselves played in allowing managed care to do this to them. Mm-hmm. Because the thing is, I don't care what kind of doctor you are, if you're a surgeon, if you're in a non-procedural field, you have the option of not working for managed care.
That's right.
But you have to be willing to go through a few first years of hardship. You got to be frugal, and then to find freedom at the end. Freedom is expensive, but a lot of them are not willing to do that. They're not willing to make the sacrifices. So I'm like, you know what? Enjoy the workload, enjoy the metabolic syndrome, enjoy finding yourself completely useless in 15 years and replaced by a nurse practitioner. You go ahead.
You said it. Yeah.
So,
yep. And I personally, I don't feel sorry for him.
No, I don't. Zero
empathy.
Choice. Zero empathy. Yep, absolutely.
Well, Shawn and I could probably say that the same for our profession, because it didn't take us long before we realized that patient wasn't just walking out with 5 medications. Pretty soon it was 10. And they didn't look better. They actually looked worse. And,
right.
The conversation I've had with clients is, you go into your vet with your pet, and the first thing we talk about is what nutritional and activity and their weight. We talk about the basics, right? Why are pets in the United States being treated better than humans?
I know.
Animals.
Right.
And I love animals, but there's just a big disconnect. And pharmacy plays a huge role in it. And our profession has sold their patients out by allowing them to have that many medications going out the door. And they're sicker and sicker and sicker. In the last 30 to 35 years, we have not improved American patients' outcomes or the health of our nation.
No.
We're at an all-time failure rate.
Yeah, we just increased the costs. That's all we did.
Yep. Obesity's epidemic, diabetes.
Yeah. So
diabetes
now I'll ask you guys, because you guys are the pharmacists. So I see a lot of pharmacists on Twitter and who talk about how they're struggling with PBMs, which is the same struggle doctors are having with insurance companies. Same exact thing: underpayment, getting you out of business, all that stuff. Why were you able? Why as a pharmacy like you able to survive this and be who you are, and those other pharmacists can't? And why are those pharmacists not refusing to take insurance for at least generic medications?
Well, it's the same thing as doctors. They get in a comfort zone. This is what they've been trained to do. We have to do it. When we went out 20 years ago and stopped doing insurance, 20 plus years ago, we were called crazy by our colleagues. We're not going to be in business in a year. You have to take the insurance for the volume, all this kind of stuff. And believe me, for a few years, it was, we had some difficulty. It was tough.
Yeah.
But we didn't have any student loan debt. That's part of the problem. That's a whole other conversation. We were able to live very frugally, and many years later, it's paying off. Financially, and we're liberated. That's priceless.
Right.
You couldn't pay me. I say this, and I'll say it over and over again. I would not work for a Walgreens for $10 million a year.
Yeah,
I'm in a place in my life.
Yep.
I love my life. I have great health. We're doing well. You could not pay me enough to work in that situation for a year. It would literally, Dr. Abdullah, kill me. It would kill me, maybe slowly.
No, I totally get you. Get you. It's not just about pay. It's about the stress and you being able to be healthy and live like a human. Have every now and then get your Fridays off. Travel, do something. So I totally get you there, and it's mind blowing how doctors who are supposed to be the health gurus, they themselves don't value their own health and get into managed care. And mind blowing.
Pharmacists are guilty of it too. I don't know how many of my colleagues they take all these drugs that they don't need because they're not metabolically healthy. It's like if you changed your diet, you wouldn't need those drugs. But back on the pharmacy thing, here's what I tell people. Well, Jan and I, we were either going to make changes. We were either going to make changes to our practice, or we were going to get out of pharmacy. I was going to go sell real estate or something. I would have rather sold real estate and do what I was doing. I don't want to, God willing, I live to be 85, 90, 100 years old, whatever. I don't want to look back on my career and say, you know what? For 50 years of my life, I was worthless. I did nothing to help anybody. And I will tell you, I have pharmacists that are my age and they're just waiting to retire in 12 years or whatever. They've got it down to the date and they feel worthless. And it's by choice. And I do not want to go through life like that. I want to make sure that I made a difference in people's lives.
Right. No, I'm right there with you. I want to feel that I come back home. I didn't make a lot of money, but you know what? I made some people very happy and I made them better. So.
Right. Because you go into a profession, especially in healthcare, as a doctor, pharmacist, nurse, whatever, to actually have an outcome of taking care of somebody and helping them in their journey of life. And if we have made their journey worse, we failed, right?
Right.
And so that was the huge part of our decision process, is we were failing. And we still live in a very rural community, which I love. But I had to look in the mirror and say, was I a part of that 50-year-old person dying because of obesity? And was I a part of that journey that didn't step up and say, hey, let's work on this, right? So there was also a lot of reflection, I think, in our hearts and our mind, like, can we live with this knowing we didn't help? We actually were a part, an accessory to, ultimately, I feel like it's a human crime. I mean, we put people in the grave one step at a time together, which I couldn't live with that every day. Like Shawn said, it was like, once you made that decision, it's like, okay, either we change the paradigm here with our profession and how we practice, or we're out.
No, I'm right there. I'm right there with you. When I made the decision to drop insurance, everybody said, you're crazy. You're going to lose business. This is dumb. You're not going to get any patients. Nobody's going to pay you. People are addicted to their insurance. And this is what I said. I said, look, all of you might be correct. And this might be suicide for me. Yeah. But my options are this. I either have my own business, charge cash, and succeed, or I stay here and get a stroke. Yeah. So I don't want to get a stroke. So if my business doesn't succeed, I'll happily work for FedEx because it beats getting a stroke. And that's really how I ended up, where I am. Yeah.
I love it. Your principle. That's really, I mean, I love it. And that's one of the reasons.
It's not even a choice to make. Like the choice was made for me. So, stroke or do this. So
that's an easy one, right?
Yeah.
So Dr. Abdullah, as we wind this podcast up, tell us what you have a passion for.
You mean right now in my practice?
Just anything. What's the first thing that comes to your mind?
Oh, okay. Well, I'll tell you what. I feel that one of the things that pushes both men and women to improve their life is actually having a healthy sex life. And having a healthy sex life pushes you beyond your limits to have the appearance. And luckily for us humans, the things that make us look good from the outside are the same things that actually are good for us in the inside. And part of the reason why I love hormone therapy is because A, it works. And then B, it improves all of these things that we value and that make life more fun. So that's part of the big passion I have for what I do. And unlike my previous job, taking insurance and doing primary care, when what I'm doing today, the patient sees value in what I do. They see the value. And when they see the value, I actually also see value in what I do. Yep. So I feel that, I actually have a real job. I'm actually important in this community. So that's that. Otherwise, I live here in Southern California. Summer is around the corner. And so the water's getting nice and warm, and I love ocean swimming. That's one of my big things. They're rejuvenating. So,
well, on the sex subject, Janet and I say it often, and we talk about sex a lot because we focus on hormones. And we have people that tell us that we save their marriage. Yeah. We have people that go from a sexless marriage to having sex 2 or 3 times a day. No lie.
Right.
Right.
Sometimes if you fix something like vaginal atrophy and dryness, with proper systemic estrogen, now the woman is not saying no anymore. Yeah. So now it's not painful anymore, Right. And same thing with the guy. Maybe he was saying no because he's too overweight or whatever, or he's not confident because he's not getting it up. But now you're helping him do that. Well, now it's a yes. So absolutely. And by the way, the sexual act is one of the few exercises on this planet that work on core, strength, and flexibility. So
Yeah, that's right.
believe it or not, fucking is actually a very good exercise. So,
well, and here's what we say. Healthy people have regular sex.
yes.
And regular sex keeps you healthy.
Yes.
Regardless of age.
Right. And I have a patient who's in his 80s, late 80s. And when I saw him the first time, he was already on testosterone, so I took over the care, and I just couldn't help it because I always like to learn from my patients. And I said to him, "Hey, so you're single, right?" He's like, "Yes." So I said to him, "So does this make you horny?" He said, "Oh yeah, it does." So I said to him, "Well, you know, what do you do with that?" You know, I was just very curious.
Right.
And because I took his history, and he's had actually a prostatectomy that went really bad. So things down there don't actually work. Yeah. So I had to ask, like, what do you do with that? And this is what he tells me. I'll never forget that. You always learn from your patients. I'm sure you guys do the same. You learn from your patients. So he said, "Dr. Abdullah, I actually don't have sex with another person, and I don't even jack off. But feeling horny makes me feel young, and that I'm still here. And he said that feeling alone makes me very happy. And I happen to be a personal trainer for seniors in my age. And he said that feeling helps me tremendously do my job." So believe it or not, sex is just beyond, you know, the euphoria of the sexual act.
Right.
There's like other things to it. So
True.
Yeah.
I say this to women a lot because when it comes up, you know, the men like to talk to Shawn, the ladies like to talk to me, but it's also a form of communication between partners that's so different, right? And if that communication's gone, there's a problem.
Right.
And you can ignore it for a while and you can put it, but it's going to come back, right?
Right.
So on all levels in a relationship, we need to work on communication, and it's how we choose to do that that's super important. And especially when I catch them young, as young moms or even menopausal, you can't say that there isn't going to be an underlying problem if we don't deal with something that is holding communication back between two people.
Absolutely. And also, one of the very good things about sex is that it helps you tolerate the bullshit of your partner. Because here's an example. I mean, you start dating someone, okay? The flesh is new, so the excitement is there. So you ignore their pet peeves. Okay, so maybe they leave their clothes on the bed, and it's annoying. Okay, maybe they don't cut their toenails as frequently as they should. You kind of let that go because the sex is good. But once the novelty of the flesh wears off, all that shit surfaces. But if you keep the sex, on a regular basis, somewhat on a regular basis, every once in a while, if you keep that, then suddenly you start forgiving each other for your other shit. So it's actually a very practical way to tolerate someone else and live with them.
Good point. All right, Dr. Abdullah, we could talk forever. We have to have you back on.
Yeah, please. Yeah.
As we wind this up, tell us if people have any questions, what's the best way to get a hold of you?
They can send a text message to our office, which is 949-229-5257. And then indeed, that is the office phone number, but we do get text messages. So people don't have to call, they can just text. And that's how anybody can get in touch with me, whether it is a patient, media, you guys, anyone. So
let me repeat that number, 949-229-5257. If you want to get a hold of Dr. Abdullah, text him. So thank you so much, Dr. Abdullah, for being on our podcast today. Our goal is to educate and empower individuals to take charge of their own health. And I think we realize that goal. So thank you so much.
No, thank you guys for having me. Always a pleasure. See you soon.
Yes, thank you to tuning in for
Take
Health
care.
Solutions with Shawn and Janet Needham. Listeners and viewers, tune in Monday to our regular scheduled podcast, Monday, 12:30 to 1:30 Pacific Standard Time. Health Solutions with Shawn and Janet Needham.